So thank you all for joining us for ASNEN's first webinar for 2018. ASNEN's a non-for-profit network run by nurses, for nurses. We seek to provide education opportunities for acute stroke nurses around the country through our webinars, state and conference workshops. They're free to join. Just visit our website, asnen.org, or you can find us on Facebook and Twitter. Just for some initial housekeeping for today's session, there may be some time for questions at the end after the presentation. And type those into the question box down the bottom. And this session will be recorded and then made available on the website in the coming days, as well as on the Stroke Foundation's Health Professional portal for me. So today we're very lucky to be joined by Professor Bruce Campbell, who's a consultant neurologist and head of hyperacute stroke at the Royal Melbourne Hospital. This year, Bruce has had his second first author publication in New England Journal of Medicine for the Extend IA T&K study, with his first being the Extend IA trial, which is one of the landmark studies demonstrating the powerful benefit of clot retrieval. And today, Bruce is going to talk to us about the implications for extending out the time window for clot retrieval after the release of the DAWN and DEFUSE 3 trials. So without any further delay from me, over to you, Bruce.
Thanks very much, Brett. It's a great pleasure to talk to you. I'll try and keep an eye on the questions and see if I can incorporate anything as we go along, but otherwise we'll do the questions at the end. So as Brett said, it's mainly about the extended time window, but we'll stray in a bit about tenecteplase as well, because obviously that's something I've been interested in. So with endovascular therapy, we all know these 5 trials that came out in 2015 and the subsequent trials, THRACE and PEACE and therapy as well. And they really were different from the previous trials, which, if you remember, it came out in 2013, the IMS3 and MR Rescue and Synthesis trials. It didn't show any benefit of thrombectomy, and the differences really were getting the artery open faster, more completely with better technology, better workflow, and also some more imaging selection, because those original trials didn't even require proof of vessel occlusion. So having at least a CT angiogram to prove there's a target for therapy was an important step up in these trials. So which sites of occlusion do the interventionists go for? Really, the evidence is strongest for the internal carotid and the M1 segment, so before the bifurcation or out to the Sylvian fissure, depending on which definition you use. Once it's bifurcated, it's smaller, you've got less definitive evidence. Certainly the trend is in the right direction for M2s, and I'm sure over time the case will build that we will treat M2s, at least the proximal ones, fairly routinely. That's already happening in many places around the world. But obviously the risk-benefit equation does change a bit as you get more distal. There's less territory at risk. TPA works better, or thrombolysis works better in those more distal arteries. And against that you have to balance the more tortuous vessels, which are potentially more at risk of perforation with the thrombectomy procedure. If you're looking at more distal M3, M4 vessels, anterior cerebrals, posterior cerebrals, they're certainly not routine at the moment. There are some situations in some centres that people will treat those. It's certainly not routine where I work at the moment. Tandem disease is where you've got the carotid occlusion or high-grade stenosis in the neck and an intracranial occlusion. They certainly benefit. Yes, they're technically more challenging. Sometimes they need an internal carotid artery stent, but they certainly benefit. Basilar artery, of course, was excluded from all of those recent trials. There are still randomised trials going on in some parts of the world. So BASICS is a consortium through the Netherlands particularly and in Europe, and they're doing a randomised trial, have been for many years. And BEST is a Chinese trial, and there's another Chinese trial, I believe, as well, which are probably going to recruit fairly rapidly, and we'll have to work out how relevant their results are to our population. So hopefully you're all very familiar with the stent thrombectomy procedure. You put the microcatheter through the clot, drop the stent in there, allow it to incubate and expand for a couple of minutes, and then pull it out under negative pressure aspiration. That's been the standard procedure in most of those trials. Aspiration using a large bore catheter is also now quite popular, and there have been some recent randomized trials. Some of you will have seen COMPASS and ASTER, which showed that they seem to be quite similar using the latest generation of large bore aspiration catheters. So you can probably do it either way, as long as you get the artery open. We talk about age, one of my favourite topics. Basically, this is data from the Hermes collaboration where you can see that as you get older, not surprisingly, the outcome, and here we've got a utility score, so 1 is perfect health, 0 is someone with a ranking of 5 or 6, and in between you've got a fairly linear measure of disability. So younger patients are going to have, on average, less disability after a stroke than older patients. But the treatment effect, which is the difference vertically between this control line and the thrombectomy line, is parallel the whole way through. So whether you're young or old, you do better with thrombectomy than you do being back in the corner. So I think that's an important point to remember. And then we just have to think about, well, is the final level of disability down here acceptable? And you can see that the median, even in quite elderly patients, is still around the 0.4, which I can't remember exactly how the ranking translates, but it's an MRS3, I suspect. Clinical severity has a very similar picture in that whether you're mild or severe, the treatment benefit is very parallel. Of course, patients with a higher NIH assessed baseline don't do as well, but they do better if you treat them than if you don't. And then there was the time window. So Mr. Clean is probably the best example of what happens if you just say anyone within 6 hours with a large vessel occlusion goes in the trial and gets thrombectomy, because they didn't have non-contrast CT aspects requirements, they didn't have CT perfusion requirements, and so it seems that if you just go on vessel occlusion and time, then it's pretty hard to push the benefit of treatment beyond about 6 hours. That's where the confidence intervals cross 1 for treatment benefit. So if you're not doing anything more than CTA, 6 hours works. But if you use all the trial data together, and of course ESCAPE used collateral selection, Swift Prime had a mixture of aspects and perfusion imaging and some MRI as well. Extend-IA, obviously, we had CT perfusion imaging at a core less than 70 mils. There were various other aspects, criteria in the other trials. And when you put together extra numbers and also those moderate levels of selection, you can push the benefit out a little bit further, maybe 7 hours and 18 minutes, I think was where the confidence intervals crossed 1 there. But there's been evidence for quite a while now, this is observational data from the DEFUSE 2 study, that if you have favourable imaging, then it probably doesn't matter how long the stroke has been going. And this was a study of about 120 patients, if I remember rightly, where they did MR in this case, and if you had a diffusion lesion less than 70 mils and a good mismatch between that and the tissue at risk, then it didn't matter really where you were at a 16-hour timescale, you would benefit from reperfusion. So of course it then took a phase 3 randomised trial to make that practice, and there were 2. The DAWN trial used a fairly complicated imaging selection protocol, which I'll show you in the subsequent slides, called clinical diffusion or clinical core mismatch. I've just highlighted Peter Mitchell's name because he was the Royal Melbourne PI for that study. It was the only Australian site. And then DEFUSE 3, which used the rapid software as well, but the more traditional paradigm of perfusion-diffusion mismatch, or CT perfusion mismatch, that we're all familiar with from the extend studies. So DAWN, as I said, 6 to 24 hours after the last known well, the majority were unknown time of onset, so wake-up strokes and so on. The only intracranial occlusions that they allowed were intracranial carotids and M1s. So they didn't allow cervical occlusion of the carotid. That was an FDA thing, that they didn't want people getting carotid stents as a second intervention. It's unproven. So ICA M1, no M2s, no neck occlusions. And then they had this very complicated paradigm that if you were younger than 80 and you had a very severe stroke with a stroke scale over 20, you're allowed 50 mils of core. So that's pretty restrictive. If you've got to be a very severe stroke, there's not many of them, you've got to be under 80, and you're only allowed 50 mils of core at best. If you're under 80 and it's a milder stroke of NIH 10 to 19, you're only allowed 30 mils of core, and if you're over 80, regardless of your stroke scale, as long as it's greater than 10, you're only allowed 20 mils of core. So it's very restrictive criteria. But with that, you get, obviously a positive trial. I've just contrasted that with the DEFUSE 3 eligibility, 6 to 16 hours, so not quite as an extended time window. NIH more liberal, 6 instead of 10. Age more liberal in a way, anyone up to 90. Pre-morbid NRS up to 2. They allowed the tandem extracranial occlusions. They allowed a definition of M1 out to the Sylvian fissure. That means there's some early bifurcation M1s, which other people would call M2s. So out to the Sylvian fissure is allowed. and then the mismatch ratio greater than 1.8, the mismatch greater than 15 mils, and essentially when you've got those large vessel occlusions, they all have that kind of mismatch, and it's really about the 70 mil core, and they allow any device, whereas DAWN was TRIGA only. So CT perfusion, how do you do it? I think everyone here should be very familiar with CT perfusion output, whether you're using Rapid, MyStar or something else. How much blood supply really is the key to this. So we're talking about core volumes not being more than 70 mils. So the threshold that we use generally is the relative cerebral blood flow less than 30% of normal brain. It's something that came out of my PhD, and Andrew Bivat came to a similar conclusion in his work, and Mass General guys came to a similar conclusion in their work. So a very severe reduction in cerebral blood flow will give you roughly what's irreversibly damaged. Obviously, there are some assumptions in that. So if we were in a theoretical scenario where patients just had a stroke in front of you and you got sound back now, okay, I don't know what happened there. Don't know how much you missed. Hopefully nothing terribly important. But I was just saying that very severe reductions in cerebral blood flow in the clinical context that we see is that patients have been going for an hour and then they have another hour to reperfuse. Generally performs very well for irreversible tissue. If you're just looking at a map visually, then a cerebral blood volume map is probably going to be easier to look at. So reduced cerebral blood volume will give you a more accurate visual impression. When you've got advanced software with thresholds, then cerebral blood flow is a more accurate representation. And then we also do look at the mismatch with the area, and this is the classic patient with a small core, large penumbra, who will do brilliantly, and their NIH at 24 will melt down to not very much at all if you get the artery open quickly. And of course, if you don't get the artery open, they have quite a poor outcome. And that was one of the really useful things to come out of these trials, is that a lot of people were concerned that if you had great collaterals to start off with, they might persist. You've gone 18 hours and you've got a small core. Maybe it's never going to be a big core, and maybe the collaterals will just go on well forever, and the patient will do quite well. And both of these trials showed very clearly that although you might have been going 18 hours with good collaterals, they don't stay that way forever. The control group did exceptionally poorly in both groups. So that was one lesson. The other lesson was that you can get half of these patients a fantastic outcome, which is just as good as the sub-6 hour trials, with an ordinal number needed to treat. So that means getting 1 point or better on the Rankin of 2 patients. So exceptionally powerful treatment. Another thing that was put about was, the clot's been there for 18 hours, it might stick to the wall of the vessel and be difficult to get out. That doesn't seem to be the case, at least in these patients with good collaterals, because 84% got successful reperfusion, which is at least as good as the sub-6 hour trials. And again, the other concern was, well, blood-brain barrier will have broken down by all these hours into it. Symptomatic hemorrhage rate was not significantly increased. It's clearly a bit higher than we see in the sub-6 hour population, but not substantially, not significantly higher than the control group. So I haven't seen any questions pop up yet, so I'll just plough on. Diffuse 3, very similar ordinal number needed to treat, very similar poor outcomes in the control group and good outcomes in the treated group. Again, high rate of successful reperfusion and a trend, but not a significant one, towards increased hemorrhage. It's something we have to watch out. It's not in the scheme of things a huge issue. So which criteria would you use? Both trials are positive. One went to 16 hours, one went to 24 hours. The reality is that the diffuse 3 criteria, apart from being a lot easier to remember, less than 70 mil core is a lot easier than their 80 and their NIHS. This is 12, therefore I'm only allowed 20 mils. The main thing is that you get 40% more patients eligible. So you're treating a lot more patients if you use diffuse 3 criteria. And of course, the next question is, well, how well do those extra patients do? And the reality is there's no difference in treatment effect between in the diffuse 3 trial, whether you were DAWN eligible or ineligible. I've got an extra slide on that coming up shortly. So my policy is within 24 hours, if you've got ICA M1 occlusion and less than 70 mils of core, then you should be thinking about thrombectomy. Here's some subgroup analysis from the DAWN trial. So you can see the overall result up the top. One of these questions was, well, a lot of these patients had unknown stroke onset. How many of them were actually within 6 hours and we just didn't know it? So they've split up the group here by last known, 6 to 12 hours, 12 to 24 hours. That was the same treatment effect. And then they've looked at the first observation of symptoms to randomisation. You can see that the ones that are known to be greater than 6 hours, which is not a huge number of patients, admittedly, had exactly the same treatment effect. So I don't think we need to worry about, was it just a trial of people who were within 6 hours and didn't know it? This is a trial that does apply throughout the 24-hour window, and that the time really is not that important. Here's another way of looking at it from the DEFUSE 3 trial. Patients sub-hour 9 hours, 9 to 12 hours, greater than 12 hours, which is 12 to 16 hours. You can see that the rate of good outcome in the thrombectomy arm was entirely consistent across those time windows, whereas in the medical arm, it got worse. And that's something that Greg Albers, who's PI on the trial, has called the late window paradox. Why does the medical treatment arm get worse the longer the stroke's been going? And maybe there's a few patients up here who got TPA and that's why they did better, but that doesn't actually seem to be the explanation. It has something to do with the kinetics of infarct growth, that patients who are wake-up strokes will be a mixture of early patients who may still have some rapid progression and later patients who have good collaterals that are persisting, and something about that gives you this kinetics of later patients having bad outcomes in the control group. This is work from Ed Rodriguez, who was a fellow with us last year, just looking at Royal Melbourne data of all the rapid cases and seeing how many patients you would get if you were using DAWN versus DEFUSE 3 criteria. And you can see that there is that 40-50% increase in patients eligible if you use DEFUSE 3. And then when we looked at the outcomes in that group, the odds ratio for benefit was just as great in the DAWN ineligible DEFUSE positive as in the double eligible patients. So if that makes sense, being DAWN eligible did not give you a better prognosis. In fact, the absolute numbers favoured the DEFUSE positive DAWN negative groups in terms of how many got independent. So there's absolutely no reason to think, oh, we're 16 to 24 hours, I'm going to use DAWN, I'm going to restrict it, and we don't need to worry about that. Here's that data on the DAWN eligibility effect. So you can see that the treatment effect, the sort of gradient on that line between MRS02 is exactly the same, but the absolute numbers, you can see that the DAWN eligible didn't have as good an independent function as the DEFUSE eligible who weren't in the DAWN, which is interesting to think about. I think it's mainly that DEFUSE 3 went down to the NIH of 6 and perhaps some more distal occlusions than DAWN had. So after all that, does time still matter? And the answer, of course, is yes, because we don't know when we get a patient whether they're going to have good collaterals or not. Overall, the stroke population is extremely time sensitive. We need to go as fast as possible with every individual patient because there's still brain cells dying. Whether you've got good collaterals or not, there's still a rate of infarct progression. What these studies mean is if you've got the individual patient in front of you who's been unavoidably delayed for whatever reason, they've woken up with it or they've been found on the floor when the relatives come home, if those patients still have favourable imaging, then they're likely to benefit from reperfusion. So it gives us extra patients to treat. It doesn't give us any extra time in which to treat them. What impact is it having? This is getting a bit old now, but it was just an illustration that our sub-6 hour thrombectomy rates have been reasonably constant for the last 12 months or so, but our greater than 6 hours have been exponentially increasing, and at that stage it was a third of all our thrombectomies were greater than 6 hours, and I suspect that's continued to increase. So we are going to revise, for those of you in Victoria, the ECR protocol to incorporate this. We decided at a recent meeting that we are going to mandate CT perfusion for all patients within 24 hours with potential reperfusion candidates. That actually wasn't me pushing that, strangely enough. It was other people who I wouldn't have thought were so fond of CT perfusion, but they felt that the need to do it in the 6 to 24-hour window is now clearly evidence-based, and to do it only in the 6 to 24-hour window and not do it sub 6 hours sort of wastes the diagnostic advantage and also doesn't bring the familiarity that doing it routinely would do, and so the quality won't be as good. So the position at the moment, unless there's some major backlash when we go out to public consultation, is that we will start getting CTP at all our remote sites through the VST program, and hopefully that will start to infiltrate interstate as well. So I wanted to talk a bit about what CT perfusion can do for you in the sub 6 hour window. I think everyone's familiar with the fact that it's very helpful for diagnosing stroke versus mimics, but how useful is it in terms of determining prognosis and treatment effect? And this is data we looked at in Hermes, paper's still in review, but you can see that the chance of getting independent drops off rapidly if you're just giving TPA, with very little chance of getting independent if your core is greater than 70 mils, which makes sense with the extend IA results. But if you do a thrombectomy, it shifts that curve up substantially. So even at quite large infarct volumes, 100, 125 mils, there's a if you look at that, that's a 10% absolute difference, so that's a number needed to treat of 10 to get an extra patient independent. I think most of us would regard that as a highly valuable thing to do. It is a little depressing to think that 9 out of 10 won't be independent, but one of them will benefit. And 0-2 is, of course, not the only benefit you get from thrombectomy. There are people who would be 3 instead of 5 or 6, and that is also quite a meaningful benefit. So we think that even out at quite large core volumes, you can get a benefit. And, of course, that was in a whole heap of patients where the overall rate of getting the artery open was about 77%. So if you look at the patients who get the artery open, there's even more benefit. So what we do when we send someone for thrombectomy is, of course, intend to get the artery open, and if you succeed in that aim, you can make a substantial difference to their outcome, even with a large core. Another way of looking at it is the absolute benefit, the Rankin shift, if you like. So the odds of being at least 1 point better off on the Rankin, and we did not count 6 to 5 as a valid shift, because most people don't think that going from death to nursing home is a great thing to do to someone. But you can see that the confidence intervals there don't cross 0 until you're getting out towards 150 mils, which is much bigger than many of us would have traditionally regarded treating stroke patients. So it's important to think about what the likely outcome is, and I'll talk about how we can be a bit more specific in who we might select at that level of core with these pretty rainbow plots. So basically what we've done here is compare someone with a small core, 10 mils, with someone with a large core of 100 mils, and then look at how age and the time from imaging to reperfusion influence the outcome you get. And the outcome here is the percentage of independent function. And if you just look at that rainbow, obviously blue colours are very low percentages, 50% around green, and hot colours are obviously very high rates. And what you can see there is even quite elderly patients can get 50% or more of independence if you're super fast and you have a small core. And then that tails off a bit. But even at relative delays, that's a couple of hours from imaging to reperfusion, which hopefully would never occur in an in-centre, and even most metropolitan transfers should be able to get reperfusion within 2 hours. You can see that you've got very good rates of independent function with a small core at a couple of hours in there. Whereas if you look at the 100 mil core, you've got to be relatively young, and although I hate age as a thing, biological age would be nicer. It's the only marker we've got in these trials. So I would treat a 58-year-old with cirrhosis and many other comorbidities much the same as I would treat a 90-year-old. Perhaps I prefer to treat the 90-year-old who's living at home independently. But anyway, age and time are really important factors, and even more critical when you've got a large core. You have very little time to salvage a good outcome at the MRS-02 level, but if you're prepared to accept an MRS-03, and at 100 mils of core, I'd certainly prefer to be MRS-03 than 5 or 6. You can see here that even out to quite elderly patients, and if you're quick, you can get a reasonable outcome. So I think that gives you some idea of how to conceptualize this when you're selecting patients. If you've got a small core, you want to be very liberal in getting people treated. If you've got a large core, if you're going to have to transfer them a couple of hours down the road, that's not great. And if you're going to have to have someone who's a bit crumbly to start off with, they're not going to do too well at the end of it all. That probably sounds like common sense. So here's an example of the 92-year-old guy who's a good 92. He's driving, he's living at home with a much younger wife. He's got a left hemiparesis dysarthria hemianopia, bad stroke score, but very, very soon after onset. So of course the non-contrast CT at this stage is not showing anything. That doesn't really tell me at 59 minutes whether he's got good collaterals or poor collaterals. We'd normally start TPA at this point, but because we were doing a connected phase trial, we got our CTP, which took 4 minutes, and then we had a daughter needle at 21 minutes in the trial. So I just wanted to put that up as an example of these trials and things we're doing at the moment can increase our daughter needle. We have seen that a bit at Royal Melbourne too. That daughter needle slipped a bit with all the various trials we're doing in the acute space with TASTE and extended RTNK and direct safe. But you can do it if you're organised. And in parallel, of course, we alerted neurointervention when we saw this distal M1 pattern. Hopefully all of you would instantly look at that CTP and say, there's a large vessel occlusion. It's in the distal right M1 because it's taking up the entirety of that territory. And there's his arch to vertex CTA with the occlusion. You can see clearly there, but also remarkably straight and non-stenotic arteries for a 92. So he's a healthy 92 in many ways. And he had a good revascularization, very little DWI change to show for it and went home. So, these are the ideal patients that now would not just be treated at 59 minutes after onset, but if he came in with a wake-up or he came in at 18 hours because he's been found on the floor and his imaging still looked that good, he deserves to be treated based on these new trials, which is very exciting. So to summarise endovascular therapy, we'd want to consider it in all patients with a large vessel occlusion, the ICA, the M1, the basilar, and some M2s, and there's a bit of discussion required for M2s. ICA M1 within 6 hours, very broad criteria, 6 to 24 hours. Really the 70 mil core is probably the best imaging selection indicator that we've got at the moment. For basilars, we still use a 24-hour time window. As I said, CT perfusion really is essential now beyond 6 hours, and I think we should be doing this at the initial hospital. There's a lot of places around the world, the US is notorious, they do a non-contrast CT, they see a hyperdense artery and they ship the patient to a comprehensive centre to have full imaging on arrival, and they won't call in the cath lab in many cases until they've seen that imaging, which introduces huge delays and a lot of futile transfers of people who never had good collaterals in the first place. So I'm very much in favour of at least making sure they've got the profile you're looking for when you start the process of transfer, and that will knock out probably about half the patients in this extended time window. And then if they've had an extended period between that imaging, you may have to repeat it when they arrive, but hopefully in many cases we'll be able to just treat on the basis of that remote imaging. Good premorbid function is important. There's a lot of discussion. We can talk about how Rankin 3 patients should be treated. In my personal view, I've just had to write a little spiel on this for the ECR protocol, is that the Rankin number is a very poor indication of what we're actually interested in. So, you know, what their cognitive function is, what their mobility is like, how well they can communicate, all those other things, and what their attitude to disability is, are very useful things to know rather than just saying Rankin 3 and ruling in or out on that basis. There's a lot of difference in a Rankin 3. There's also Rankin 4s that we might want to treat, for instance, you know, someone who's 30 because they've got, and in a wheelchair because they've got spinal muscular atrophy or something that's relatively non-progressive, has a stroke, they're technically MRS4 because they're in a wheelchair, that you might want to consider treating that. And Bronwyn's asked a question, is there any role of assessing collaterals prior to transfer from a peripheral centre? Hopefully I've just answered that in that I think there definitely is, and I think you know, there are a number of benefits of peripheral centres of doing a CT perfusion. I think it's easier to look at the CTP than the CTA, so it tells you there's occlusion. You know, doing VST, it's often unclear from clinical factors whether it's a stroke even, and we've had instances on VST where even experienced people have missed the fact that there's an M1 occlusion because the CTA is not great, and if we had CTP routinely, that would never happen. So I think, you know, there are a number of reasons why we should be doing it at the peripheral centre. It will improve the quality of care or improve people's understanding of stroke out there. Might even get some more emergency physicians buying into it because they seem to like it when they can see a stroke on the imaging rather than having to trust us that it's there on the basis of a normal non-con. I don't think age or clinical severity should be limiting factors on their own. And also the core volume within 6 hours shouldn't be a limiting factor on its own. I think we need to integrate multiple factors together. Thrombolysis, for the moment, we give in parallel subject to the results of these trials that are going on about direct thrombolysis, which we can talk about if you like. So you probably know that the AHA guidelines revised and went for this rather complicated thing of within 6 to 16 you can use DAWN or DEFUSE, within 6 to 24 hours you have to use DAWN. 16 to 24 hours you have to use DAWN. That's really because the way they rate their evidence, to get a level 1 recommendation in their system, you have to have 2 positive randomised trials in that population. It's a bit less flexible than what we have in Australia. There's a lot of controversy around the AHA guidelines, and we realise that a whole chunk of them were rescinded and will have to be re-released once they work out their wording. So the informme.org.au site, hopefully you've all been to, and you're looking at your own stroke data because that's where all the OSCA data ends up and the audit data. But the guidelines are on that, and we have a draft guideline. This is the draft guideline for those who didn't see it during the consultation period. So for patients with an ischemic stroke caused by large vessel occlusion, the ICA proximal M1 or with tandem occlusion, endovascular therapy should be undertaken, and the procedure can be commenced within 6 to 24 hours after they are last known to be well, if clinical and radiological features indicate the presence of salvageable brain tissue. Now, this is the pro and con of the Australian system, is we can be a little more conceptual, and so rather than split the 6 to 16 and 16 to 24 hours, we've made the conclusion from all the data that there is no effective time within that window, and therefore we're not going to split it. And we've also cited salvageable brain tissue. You can use clinical core mismatch if you want, but what I would suggest is that you use the 70 mil core volume that was in DEFUSE 3. It's just a lot easier and treats a lot more patients with benefit. There's all sorts of practical information. I'd encourage you to go and read that, talking about the rationale for why we feel there's no time effect, etc. And of course now the role of intravenous thrombolysis. So I'm going to shift tack a bit now and talk a bit about what we should be doing with intravenous thrombolysis in the current context. In PCI, or in STEMI, obviously PCI has really taken over in the metropolitan area, so thrombolysis is almost never done in metropolitan Melbourne and other metropolitan centres, but it is still the standard and in fact given in the ambulance in rural centres where there's more than about 90 minutes to balloon time for the cardiac, and they use tenecteplase, of course, at a higher dose than we do. For Royal Melbourne Hospital, 75% of our caseload is transferred. And from Felix NG's work with the Box Hill and the local team, we know that if you ship a patient even around metropolitan Melbourne, that induces a 2-hour delay in getting the artery open with clot retrieval. So there's clearly time in transfer patients for thrombolysis to achieve earlier reperfusion, and there's evidence from tenecteplase that we might be able to do that more efficiently and conveniently and cheaply as well. So that was a comparison of Extend-IA results at 24 hours with endovascular thrombectomy versus tenecteplase versus alteplase at 24 hours. Now it's a little bit of a cheeky comparison because this trial of Mark's didn't have ICA occlusions in it, which of course are less likely to dissolve with tenecteplase or alteplase. And what we really want to know about is what happens in the first 1 to 2 hours, not 24 hours, because reperfusion at 24 hours may not salvage as much tissue, or almost certainly won't salvage as much tissue. The individual patient data meta-analysis on tenecteplase is in the promising but unproven zone, so there's a lot of things on the correct side of the line. MRS 01, 02, ordinal MRS are all looking favourable but not statistically significant with the data prior to 2017. And sitch rate sits on the good side of the line as well, but not significantly different in any way. Then NOR-TEST came along, huge trial, 1,100 patients, super mild, median NIH of 4. About 17% of them actually didn't have a stroke, and only 15% had a vessel occlusion, 3.7% went on to thrombectomy. So very mild stroke population, no significant difference. It's nice to see the lines going in that direction, but you really can't say anything about the efficacy of tenecteplase being better than alteplase. It just looks no worse than. I think you'd be reasonably confident about that. And the safety was also quite comparable, which was reassuring given they use this higher dose. So Extend-IA 10K hopefully have all either been involved in the study or seen the results of it, but it was an investigator-initiated non-inferiority design. The reason non-inferiority because we felt given tenecteplase is easier to give and cheaper, people would switch if it was as least as good as TPA. 202 patients, 1-to-1 randomisation. Primary outcome was whether the artery was open at the initial angiogram, and we went on to test superiority if non-inferiority was demonstrated. Very broad criteria. Essentially, if the patient was eligible for thrombolysis and thrombectomy, they could have been in this trial. We didn't have a maximum core volume after the first 80 patients. And the demographics were very typical large vessel stroke, so around the age of 70, around the NIH of 17. Takes about 2 hours from the stroke onset to getting the thrombolysis. That is unfortunately common in Australia. It's much longer than, say, the Mr. Clean trial was sitting around 80 minutes, so they have much shorter pre-hospital distances and times than we do. It's just the geography and also the way people call AAA. And then lysis to puncture was a median of 43 minutes, so there wasn't a lot of time for the tenecteplase and alteplase to work. In fact, on average, the alteplase infusion had not finished by the time they punctured the groin. And that's one of the issues. So the distribution of vessel occlusion is very typical again for large vessels, so predominantly M1s, 60% M1s, 25% carotids, and a few distal M2s and the occasional basilar. This was the primary outcome, so 22% opened with tenecteplase versus 10% with alteplase, not just non-inferior but superior. And then the surprise we got was that the Rankin distribution was actually significantly improved on a shift analysis. So odds ratio of 1.7, which is about the odds ratio we had in some of the thrombectomy versus control trials. So it's a significant magnitude of effect. And the question is that just the 10% of patients who've had an earlier reperfusion, or is there other stuff going on? There's a lot of theoretical concerns, at least in animals, about TPA toxicity and blood-brain barrier injury and all those sort of things. So it's not fully explained, but it certainly seems think we can be very confident that the outcomes with tenecteplase will be at least as good as with alteplase, and almost certainly better. The safety profile was not a concern. Death, if anything, favoured tenecteplase. In fact, the New England Journal made me reanalyse death in a different way, which gave us a p-value of 0.049, which I didn't emphasise, but it's very close to being a significant reduction in mortality. Extend-IAT conclusions was that tenecteplase got the artery open better. For every 9 patients that you treat with tenecteplase rather than alteplase, you don't have to do a thrombectomy at all, which is pretty good. And 1 in 5 in total tenecteplase treated patients who don't need a thrombectomy. There's no safety concerns, there's improved functional outcomes, there's convenience of a single bolus, and it's fast. All of you who've transported people with an infusion running know that it gets tangled or it gets occluded or it gets ripped out. That it doesn't happen. If you've given a bolus, you know it's gone in, you've given it a flush, you can move on to thinking about other things. So cost difference in Australia is about $2,000 because anyone over 55 kilograms of course needs more than 1 vial of TPA, and it's always only 1 vial of TNK. So, to summarise the entire talk, DAWN and DEFUSE 3 really have led to a major expansion in thrombectomy eligibility. It's particularly relevant in Australia with our long distances. It really opens up the accessibility of thrombectomy to a lot of our rural sites where we were struggling to get them down within 6 hours beforehand. But as I said, it really does not give us any excuse to take any longer in that process. We really have to get them down as fast as possible, and we need to get that CT perfusion done up front so we get the right patients transferred. Tenecteplase is looking very promising. We're now, as many of you know, doing a dose comparison to see if the Nortest dose is any better. You think that if anyone was going to benefit from a higher dose, it would be those with a large clot burden with large vessel occlusion. You think that if anyone was going to benefit from a higher dose, it would be those with a large clot burden with large vessel occlusion. So we'll see, and we've got that going in the mobile stroke unit as well. So I think that's all I had in the way of slides. So I'm happy to take questions. Let's see. Typing at the moment. Brett, did you want to ask a question while we're waiting for someone to pop up? Put you on the spot.
Thanks, Bruce. That's excellent. I guess my question, now that we know that TNK works for large vessel occlusions, I mean, should we be moving towards trying to use that as standard of care? Yeah.
I think it's very reasonable to use TNK in large vessel occlusion as standard of care, and many of you have already got hospital formula applications done or underway to be able to use it when you want to. I think in the non-large vessel, it's really important that we finish trials like TASTE. We need that direct comparison with TPA without the confusing effect of thrombectomy, and if we can get a positive or even a non-inferior TASTE result, then that really will change practice for the entirety of stroke patients, not the large vessels. So I think we've got that opportunity now to do this trial, to finish it off. It's recruiting well, so we just need to get it done. I encourage you all to get involved in TASTE if you're not already, and really push that question through.
I can see Lizzie Dodd madly typing a question away.
So I'll just talk a bit about that. So the direct thrombectomy thing is an interesting question. It really only applies to people who work at places like the Royal Melbourne, where you've got a thrombectomy table immediately available. And to be honest, even after hours, I'm a little uncomfortable about it because we still have about 90-minute delay between when you could have given lysis and when you could do a thrombectomy. So it's really, for me, an in hours, you've got the table ready and waiting. Doesn't make a difference to give thrombolysis. If you're transferring patients, I do not want to see people withholding thrombolysis with this lack of evidence. Yeah, so Royal Adelaide obviously are doing a fantastic job. The centralised system we've got in South Australia really is unique. I mean, we've got a reasonably well set up system in Victoria. The advantage we have is the telestroke network, and I know there's moves to get that out to rural South Australia. Lots of exciting stuff. Those in New South Wales, interested to hear how you're finding things now. I think the system's starting to improve a bit. You're not necessarily having to call 6 people before you know that to send a patient. Just wait for the next question. I'd be interested to see if there are centres that haven't introduced 6 to 24-hour thrombectomy, or thanks for that. So yeah, are there sites that are having trouble implementing the 6 to 24-hour window, or are they having questions about how they use the selection criteria? So does the TNK trial have the same time frames for thrombolysis? Yeah, both TASTE and extended TNK have stuck within the 4.5-hour window. Now it's interesting, Genentech, who supply TNK and alteplase in the United States, are actually seriously considering an extended window trial of thrombolysis. So they're going to do adding tenecteplase to thrombectomy in the 6 to 24 hours, which the rationale is in transferred patients who might be able to get faster reperfusion. And getting CTA and perfusion country CT scans. Look, I always hold up the example of Bairnsdale, which is a small GP-run hospital out in Gippsland. They do some of the best CT perfusion and CT angiography of any of our centres, and so I figure that if they can do it, then I can shame the larger rural centres into doing it. And generally, there's not been too much opposition. There are some centres that are faster to adopt than others, but we've got, I think, 6 out of the 16 doing CT perfusion regularly, and the others are sort of looking at how they can get it going. There's obviously issues with radiographer training, and some of these places don't have a radiographer in the house after hours and they have to call them in, but CT perfusion really is not difficult. They've all our telestroke centres now do CTA routinely, and that's a whole lot more complicated than CTP. With CTP, you just press the start button at the same time you press the contrast button. With CTA, obviously you've got to worry about the timing. Do I do CTP before CTA? The answer is yes. It doesn't matter from a technical point of view. Obviously, the contrast is there if you've done a CTA, but the way we do CTP is to reset it versus a baseline. So it doesn't matter if there's some contrast floating around in the system before the CTP, but from a practical point of view, if I'm trying to make a treatment decision, what's going to help me if I haven't been able to make it on the non-con is the CTP, because if I was uncertain whether it's a stroke, it's the CTP rather than the CTA that will most quickly tell me whether it's a stroke or not. If I see a large vessel occlusion pattern on the CTP, then I know where to look and I know what I'll see on the CTA. So really for me, the decision is all made on the CTP, how much tissue there is, what sort of vessel occlusion it is, and then the CTA really just tells me about the proximal access and the mechanism. So are the interventionists going to have trouble accessing it? Is it atherosclerosis? Is it dissection? What else is going on that we need to know about in planning the clot retrieval procedure? Do our ambulance crews now bypass to an ECR centre out to 24 hours? In Victoria, no one bypasses anywhere at any time yet. So the answer is no. But Henry Jow's developed this Act Fast tool, and in the West, obviously Darshan's using the RACE tool. In the States, they are doing limited bypass, so if you've got less than about 15-minute travel time distance between a comprehensive and a primary, they'll go to comprehensive if you've got a stroke screen, RACE or LAMS or whatever that looks like large vessel occlusion. So there's a lot of work to be done in the space, but we're just getting towards lights and sirens responses for sub 24 hours. That's my next challenge, because at the moment they don't do that beyond 6 hours. And then, the triage of large vessel occlusion is the next step to make sure these clinical tools are accurate enough to do that. The obvious downside of triaging someone to an endovascular centre and bypassing a primary centre is if they actually didn't need a thrombectomy, they just needed thrombolysis, and then you've delayed their thrombolysis, which is suboptimal. Alrighty. Still some questions being typed by looks of it.
Might take 2 more questions and then we might wrap it up.
My voice might fade if I talk much longer, so try to keep concise answers. Everyone stop typing.
Too much pressure.
All right.
Just before we go, we've got a couple of ASNEN events up and coming. So our next webinar is on the 22nd of August, and that'll be on mood, depression, anxiety and palliation in stroke. It'll be presented by Dr. Jasmine Turner, clinical psychologist at the Royal Adelaide Hospital. And then hopefully you'll be able to join us, for as many of you as possible, at Stroke 2018 in Sydney, where we have an ASNEN symposium as well. So hopefully you'll be able to join us for that. We'll have Scott Coote presenting on the Melbourne Mobile Stroke Unit. There'll be a panel of case studies presented by Lizzie Dodd, Megan Osborne and myself, Brett Jones, on the Weird, Wacky and Wonderful. And Liz O'Brien will also be presenting about our issue with not getting hemorrhage patients into stroke unit beds. So titled Blood in the Head, but not in the stroke bed. So hopefully you'll be able to join us for those. So thank you again for joining us. And thank you again to Bruce for giving up his time to prepare the presentation and present and lose his voice. And thank you all for those who asked questions, and great to see representation from across the ditch in New Zealand. Thank you, Bronwyn, and thank you all. And thank you to WA for joining us across the time zones.
Good on you guys.
Thank you all.